WHO, particularly the Department of Reproductive Health, and Metin Wilmesoglu and Mariana Bimil for supporting me to be here. So thank you very much to them. I'm going to give a talk about active management of third stage of labor. So this is, as we saw before, this is a very effective intervention to reduce postpartum hemorrhage. And I think it deserves an attention in all the processes. And I would like to show you what are the sources of the data that I'm going to show you. This is one of guidelines by WHO, which is the WHO recommendation for the prevention and treatment of postpartum hemorrhage. Also, there is a guideline on delayed umbilical cord clamping for improved maternal and family health and nutrition outcomes, performed by WHO also, recently published in year 2014. And I started data from the Cochrane Library, where there is a bunch of systematic reviews dealing with this problem of postpartum hemorrhage. Also the WHO Reproductive Health Library, and I would like to mention particularly to a systematic review or written for Gavin and a group of scientists, effects of placental transfusion in extremely low birth weight infants, which is a meta-analysis of long and short-term outcomes, because there is a gap in this issue. So these are the sources of the data that I would like to show you. Also, I think we must speak in the same language. And when we say which is postpartum hemorrhage, we should know what is postpartum hemorrhage. Postpartum hemorrhage is any blood loss equal or more than 500 milliliters protogenitally tract during delivery. And moderate is when it's equal or more than 500 milliliters, and severe when it's more than or equal to 1,000. I recommend this because in some of the studies they say postpartum hemorrhage, but they don't define what is postpartum hemorrhage, and the way it was measured. And I think it's important to measure the blood loss, and it's important to define what is blood loss postpartum hemorrhage. Some time ago, in year 2008, we joined with Metin and a group of our institution. We published the prevalence of PPH, and here we can see that overall the prevalence of PPH equal or more than 500 milliliters is nearly 6%, and you can see the intervals, the confidence intervals are very narrow. When the blood loss was objectively assessed, you can see it was nearly 10%, and when it was subjectively assessed, it was 7%. This is why I'm saying is there is a need for assess the blood loss in a very objective way. Also, in prevalence of PPH, we can see it's nearly 2%, and when it's objectively assessed, it's 3%, and also is 1% and 68% when it's subjectively assessed. this is to show you that the problem is there and we should measure it. I'm not going to go through all the problem with maternal mortality and PPH because it was said by Zahida and the previous speaker. But it's worth to say that it's a problem of our region. The contribution to maternal mortality in the developing region is 20%. And you see here in the developing region is only 8%. This was published and was shown by Zahida. That is an article from Leigh Sale in the Lancet Global Health in the year 2014. And you can see here what are the regions where postpartum hemorrhage contributing mostly. Here in Northern Africa, Eastern Asia, and Southern Asia. This is only to show where the problem is. But I think there is heterogeneity all around the world with the contribution of maternal mortality from PPH. And I think every region, every hospital, every country has to measure what is the contribution of PPH. But at the end of the story, PPH is one of the great killers of mothers. So it deserves attention, the prevention and treatment of postpartum hemorrhage. Here's a statement from Blum that says most of the health gains in the developing world are attributable to public health effort to prevent illness, not just heroic measures to treat diseases. So we are dealing with this multi-intervention that is the active management of first stage of labor in the field of prevention. So we are following this statement. But it's not a question only of the clinical aspect. You see here active management using Uterotonic, which drug, which dose, which route, timing, core clamping timing, and controlled contraction. But also, it's a question of system and environment. We should see what is the provider's skills, what is the satisfaction of the women and provider, what is the injection safety, and what are the storage conditions of the system to make the choice of the best intervention for PPH prevention. Also cost, as purchase costs and indirect costs are important to make a balance on the different interventions we are going to use in our setting. Going directly, what is active management of third stage of labor is the administration of an uterotonic after delivery of the baby, early cord clamping and cutting, and controlled contraction to deliver the placenta in the first uterine contraction. So this was described by Spencer many years ago, was introduced in the clinical field without any proof that was effective. So there were a lot of problems with that because then we have to do clinical trials and also to see what are the contributions of each one of these interventions. And the other problem is the interventions are not influencing the maternal health, but also the neonatal health. Following how we construct the evidence, I think we should define maternal priority outcomes And here you can see the maternal priority outcomes: maternal death, blood loss severe and moderate, blood transfusion, and use of additional uterotonic. This is maternal priority outcomes. As I said before, we should see also neonatal priority outcomes. In terms of babies' neonatal death, which is unrealistic to measure, but we should measure because there are only few neonatal deaths at term. Respiratory stress syndrome, hyperbilirubinemia, polycythemia, anemia, iron stores, and neurodevelopment. And there are some indicators, some outcomes in preterm that are particularly from that gestational age, that are intraventricular hemorrhage, blood transfusion, necrotizing enterocolitis, and sepsis, plus all this. Okay? So, once we get the evidence in our hands, and we define the intervention, and we define the outcome, to make a recommendation, we assess the evidence. And the evidence is high. When further research is very unlikely to change our estimated effect. Moderate, when it's likely to change the estimate, further research. Low is very likely to change the estimates if research comes. And very low, any estimated effect is very uncertain. After that, a group of experts with the evidence in their hands, they give a recommendation and base it in the overall risk-benefit ratio. And a strong recommendation is that when the effects, desirable effects of the recommendation outweigh the undesirable effects, and weak recommendation when the effects probably outweigh the desirable effects, outweigh the undesirable effects. So, going to the evidence showing if this intervention is effective, there is a Cochrane systematic review with 7 trials and almost or more than 8,000 women. There are different combinations of the components, and not so clear, active and passive, but we can have an estimate, and these estimates say that active management of third stage of labor reduces PPH, severe PPH, moderate PPH, and maternal blood transfusion almost 65%. It's very effective intervention. And therapeutic uterotonics reduces 80%. So this is very effective. But this is an advice for every intervention we are going to introduce or we are doing in our clinical practice. When we introduce an intervention, there are beneficial effects, but also there are harms. Generally, we mention benefits, and we keep apart the harms. And our advice is, please take in account the harms, because, for example, this, you can see that increases the lower average bed weight because you are performing core clamping immediately, and this causes lower average bed weight. Are you causing maternal hypertension because you are using ergot derivatives? Pains because this derivative ergot produced after pain, return to hospital will be there. Trying to overcome this problem and trying to refine our intervention, there was trials trying to address these issues. Which is the uterotonic drug of choice? What is the core clamping timing? or whether to perform controlled contraction. Referring to uterotonic drugs for active management of first stage of labor, I will be brief in this because there is a session dedicated to the uterotonics. And use of a uterotonic for the prevention of PPH is recommended for all births. The guideline from WHO says strong recommendation, moderate quality evidence. Oxytocin is a recommended uterine drug, strong recommendation, moderate quality evidence. And where oxytocin is not available, we can use ergots, oxytocin plus ergometrin, or misoprostol sublingual. A strong recommendation and moderate quality evidence. I think a paragraph apart deserves carbetocin, that in the guideline said that carbetocin is similar in terms of severe PPH, but more expensive. Then, as you see, carbetocin now is being tested in the form of room thermostable form in a big trial. Mariana is going to talk about this. So there is a gap there. And in respect to the early cord clamping term, the benefits of early cord clamping is neonatal phototherapy. But this isn't that, because the trials showing that neonatal phototherapy was needed was the first trial many years ago. The more recent trial doesn't show this. Harms higher low hemoglobin level at 24.48 hours and iron infant deficiency. So early cord clamping term has harms and practically no benefit. No difference in respiratory distress syndrome, polycythemia, anemia, or infant neurodevelopment. Going to early cord clamping in Preterm, benefits? No. Higher IVH, higher blood transfusion, higher necrotizing enterocolitis, and higher sepsis. I should say, or must say, that this comes from very small trials with dubious methodological quality. So it deserves to be more researched. No difference in death, respiratory distress syndrome, hyperbilirubinemia, and uncertain in infant neurodevelopment. Okay. So, in view of the evidence available, late cord clamping performed 1 to 3 minutes after birth is recommended for all births where initiation is simultaneous, essentially repair. A strong recommendation, moderate quality evidence. And controlled contraction for active management of first stage labor. Although there are no significant differences in PPH, severe PPH, as controlled contraction reduces manual removal of placenta and moderate PPH, it should be used in active management first stage labor, weak recommendation, high quality evidence, but this is important. Only recommended in settings where skilled birth attendants are available. So, what are the conclusions of my talk? In reference to research, uterotonic drug, carbetocin, room thermostable. We are doing a big trial to answer this question. Uterotonic timing, when it will be given the uterotonic, when the shoulders appears, when the baby is delivered, when the placenta is delivered. Well, we are doing we are about to start a trial of uterotonic timing, given the uterotonic immediately after delivery of the baby, and then at 3 minutes after delivery of the baby. Uterotonic route, which is the base route, intramuscular, or intravenous. I heard from Genuity that they are planning a randomized trial in this issue. And I think this is the most important issue in umbilical cord clamping timing in extremely low birth weight babies. I'm talking about babies less than 1,200 grams. And maybe we are biased, but two of us are doing this. Lilia, who is the person leading a randomized controlled trial comparing cord clamping timing. She finished the pilot, and we in America, in Latin America, are struggling to get some funds to start a trial like this. So these are the questions. But for the clinical practice, for the daily work, active management of third stage of labor is recommended as gold standard to deliver the placenta and to prevent PPH. In which way? With oxytocin, 10 units, international unit, intramuscular or intravenous, cord clamping from 1 to 3 minutes after birth. In our trial, we showed that 3 minutes is better than 1 minute. And controlled contraction where the birth attendant has the necessary. Thank you very much. Oops.